Our general principle in vascular surgery is to preserve vessels whenever we can. I mean, the reason we embolize many times is due to lack of an alternative. Embolization is associated with complications. It can cause buttock claudication, it can cause sexual dysfunction, and rarely it can cause devastating complications of ischemic colitis or paraplegia. And that can at large be avoided by preserving the internal iliac artery. I would say also that preserving the internal iliac artery may be very important in patients with complex aneurysms that extend to the chest to minimize the risk of paralysis when we do a secondary procedure.
If someone were to ask me why iliac preservation is necessary, there's multiple reasons why that's the case. I mean, probably the first and most important thing is it's probably the best thing for patients, that we should maintain and preserve pelvic perfusion. It's important for quality of life. Even if many of the complications aren't life-threatening, they do have an impact on patients' lives. Secondly, as vascular surgeons, our whole job is about fixing and preserving blood vessels. So if we can avoid sacrificing an important blood vessel, we should do that.
We know that the Achilles heel of endovascular for those complex thoracic aortic pathologies has been spinal cord ischemia. One of the most important networks of flow to the spinal cord comes from the internal iliac. So as more future pipeline devices are approaching, we need to be wary of the fact that simply embolizing the internal iliac is probably not in the patient's best long-term interest.
All comes down to preservation of flow. Any named vessel, and I think most vascular surgeons would agree, if patency can be preserved, we should preserve flow in that named vessel. There's no reason to sacrifice a major vessel and subject patients to potential risks if flow can be preserved. And with the iliac branched endoprosthesis, we're able to preserve that flow.